A continuación tenemos al doctor Max Zafereo. El doctor Zafereo es cirujano de cabeza y cuello del MD Anderson de los Estados Unidos en Texas. Él nos va a conversar en el día de hoy sobre el carcinoma anaplásico medular diferenciado de tiroides agresivo, integración de la terapia sistémica y la cirugía. Bienvenido, doctor Zafereo. Adelante.
Hello, it is a distinct honor to present at the 2020 Head and Neck Surgery Conference at Centro Médico Docente La Trinidad in Caracas, Venezuela. I'm Mark Zafereo, Head and Neck Surgeon at MD Anderson, and today I will be speaking to you about anaplastic medullary and biologically aggressive differentiated thyroid cancer and how we are integrating systemic therapy with surgery in 2020. I do have clinical trial research funding from Merck and Eli Lilly, as well as I'm a medical advisor for Eli Lilly. Our learning objectives are as stated previously. We are going to talk about the indications and current evidence and practice for integration of neoadjuvant targeted therapy with surgery for anaplastic medullary and advanced differentiated thyroid cancer. It always helps to bring the presentation to real life with a patient presentation. So this is a 60-year-old gentleman, otherwise healthy, with a 1-month history of a rapidly growing neck mass. He has mild dysphagia. He's breathing well at rest, but he does have to sit in a chair to sleep at night. And you can sort of hear some mildly audible stridor when he breathes deeply. On flexible laryngoscopy, you cannot even see his vocal cords because of laryngeal edema. And this is, you can see his picture here. You can see his neck is very large here with a large neck mass. And this is a presentation that many of us may be familiar with for somebody who presents with a rapidly growing anaplastic thyroid cancer. So pathology from a core needle biopsy suggested anaplastic, and biopsy of a lymph node suggested mixed anaplastic and papillary thyroid cancer. This patient does not have distant metastasis, and his tumor does have a BRAF V600E mutation, as well as a TP53 mutation. If we look at his CT imaging on the left here, this is at the level of the hyoid bone. We see that the carotid artery is 360-degree encased in disease. Here's the carotid artery here. On the right, similarly, this is a little bit lower down. You see carotid artery here and encased in disease. And the PET scan tells it all, really. Obviously, all of this black here representing significant, highly PET-avid tumor on the coronal and the sagittal images in the neck. So what do we do for genetic molecular testing for anaplastic thyroid cancer in order to look for tumor mutations, which is critical in 2020, as we will demonstrate shortly. So there's 3 ways that we can do this. One, the fastest way is by immunohistochemistry staining for individual mutations. So this can be done from typically a cell block or a core needle biopsy, and then you do IHC for BRAF V600E, and you can also do it for other mutations. This typically takes 3 or 4 days to get the result. Next generation sequencing is sort of the gold standard. This is where you may send the specimen to Foundation One, which is a commercial company, or many individual institutions like MD Anderson and others have individual institutional platforms for next generation sequencing, where a standard platform of 200, 300, 400 genes will be sequenced. That typically takes 1 to 2 weeks to come back, so that it takes a little bit longer. Liquid biopsy is a relatively newer technique that is being studied to look at blood, using the patient's blood, and with the idea that these aggressive tumors often secrete tumor DNA into the blood, which then can be tested for tumor mutations. And we have published some data which shows some concordance between liquid biopsy and next generation sequencing. So when we look at anaplastic thyroid cancer, we know that about 40% of these patients do have the BRAF V600E mutation. Another 25% have probably a little bit higher than this, have a RAS mutation, and a smattering of other mutations, and then about a quarter of patients have no targetable mutations. The most important of these being and most common of these being the BRAF V600E mutation, which is a targetable mutation. And this study, published in JCO 2 years ago, was a landmark study that ultimately led to the FDA approval of dabrafenib and trametinib, which is a BRAF and MEK inhibitor combination, the first FDA-approved drugs for anaplastic thyroid cancer. So in addition to the BRAF MEK inhibition, there are several other combinations other than dabrafenib and trametinib. There's vemurafenib, cobimetinib, another BRAF MEK inhibitor. There are other targetable mutations in anaplastic thyroid cancer, particularly fusions. So the RET fusions, these are present in only about 1% of anaplastic thyroid cancer, but there are now actually 2 FDA-approved agents, LOXO-292, which is now selpercatinib, and BLU-667 for pralsetinib, for RET-fused anaplastic thyroid cancer. NTRK fusions can be treated with entrectinib and larotrectinib, which are FDA approved as an agnostic indication for cancers with NTRK fusions. And then ALK fusions can be treated with ALK-specific inhibitors, although these drugs are not FDA approved at present. So responses of the BRAF mutated anaplastic thyroid cancer to BRAF MEK inhibitors are generally very rapid and dramatic. And as demonstrated here, this is a patient 68-year-old gentleman who presented with a BRAF V600E mutation, anaplastic thyroid cancer, treated with dabrafenib and trametinib. This was before his treatment. You see a massive amount of tumor in his neck, including all these sort of dermal metastases. 5 weeks later, with this BRAF MEK inhibitor combination, you see that this tumor has completely resolved, and it's quite amazing results that we see, very rapid and dramatic results. You look at a PET scan. So this is a patient who had 3 months of dabrafenib, trametinib, and pembrolizumab, which is a type of immunotherapy, PD-1 inhibitor. You see significant activity in the neck and in the mediastinum here. And all of this resolves after 3 months of dabrafenib, trametinib, and pembrolizumab. So back to our patient. So he went on, and this patient was presented in 2017. He was on dabrafenib, trametinib for 4 weeks, and then he had a remarkable response. If you look at his neck now as compared to those images we just saw a few moments ago, his CT and PET scan, you see a dramatic response. And you look at his actual neck. You remember that picture with that bulky tumor in his neck, and now his neck looks more normal. So he's had a significant and dramatic response, rapid response in these 4 weeks, but he does have a little left supraclavicular tumor that's growing, and actually you can see it here on the CT scan. So at this time, we decided to biopsy that tumor, which was growing while everything else was dramatically shrinking, and it did have a emergence of an NRAS mutation, and this has been described. We published a paper on this. It's relatively rare, but it does bring up a challenging scenario where you're having a dramatic response, and then you have this emergence of a new mutation. So we added pembrolizumab at that time, again, immunotherapy at week 5, and he was treated with this combination for an additional 8 weeks, dabrafenib, trametinib, and pembrolizumab, so-called DTP. So when we look at these BRAF inhibitors and their effect on overall survival in anaplastic thyroid cancer, this was a paper that was presented at ASCO 2 years ago by Dr. Jen Wong, who is a surgeon here at MD Anderson. So we look at the top line here, the figure on the left. This is the blue line is those patients with BRAF mutation who got BRAF inhibitor. The bottom line here is those with BRAF mutation who did not get a BRAF inhibitor. And you see a significant difference in the survival of these patients. You can see the significant p-value here. But if you look at the time frame for this, and this is overall survival, this only goes out to 1 year on this curve. And I did this just to make the point. When you span this out to multiple years, you see that these patients who are treated with BRAF inhibitor, and this is just to be clear, this is something we would never do in this day and age because all of these patients would be getting a BRAF-MEK inhibitor combination, being given the dramatic results that we have seen. But we are able to use historical data to demonstrate this. So these are the patients who had BRAF mutation, BRAF inhibitor. You can see up to a year they're doing great, and then at about a year there's a rapid fall off in terms of their overall survival, to where it actually almost between 1 and 2 years starts to approximate those patients who were not treated with a BRAF inhibitor. And so really we see that we see these patients do really well for the first year, but then there's this emergence of resistance. And so that brings us back to this patient. He actually had an early emergence of resistance. It was only at week 5, so we added immunotherapy at that point. And so we're all familiar with PD-1, PD-L1 inhibitors, pembrolizumab being one example, with Tasalizumab, nivolumab, other examples. They work at this PD-1, PD-L1 interface. And it's important to note that anaplastic thyroid cancer has a very hot immunogenic environment. So this is looking at intratumoral PD-L1 scores. This was presented by one of the endocrine oncologists here at MD Anderson, Ramona Dedu, at the American Thyroid Association meeting several years ago, showing very hot immune microenvironment for anaplastic cancer. And amongst those that have the BRAF V600E mutation, we see an even higher median PD-L1 score and percentage of positive cells. So the BRAF V600E in particular may be the most immunogenic for amongst the anaplastic thyroid cancer patients. So back to our patients, he gets this combination of BRAF-MEK inhibitor and immunotherapy for 13 weeks. And you can see dramatic response here in the neck. So now that the tumor is, you can see the thyroid here, you see the tumor, you see a little bit of tumor outside of the thyroid, but this is the carotid artery, and it's no longer 360-degree significantly encased in tumor, and actually higher in the neck at the level of the hyoid bone. Now you see that you can't even see any tumor here. And really the PET scan again speaks 1,000 words. This is what we started with on the left, significant PET avid tumor, and after 13 weeks of DTP, you have still have some FDG avid activity in the neck, but a dramatically different scenario than what we had just 13 weeks previously. And so at this point, we took this patient for surgery, understanding this pattern of resistance that often develops in these patients. We realized that that we needed to get this residual disease, this residual PET avid disease out, so that in a few months or a year from now, we wouldn't be back in the situation with significant PET avid disease. So we did a thyroid central neck and lateral neck surgery. He did have multifocal bilateral residual anaplastic cancer, including 15 metastatic anaplastic lymph nodes, and also had some differentiated thyroid cancer, papillary cancer in the specimen as well, 13 papillary cancer lymph nodes. And this brings up an important point for patients who have anaplastic thyroid cancer, which is derived from a papillary thyroid cancer lineage. Those patients are going to be BRAF mutated, and when you treat them with the BRAF-MEK inhibitor combination, oftentimes you'll see a significant reduction response in the anaplastic component, but you still see this papillary component which remains. This patient actually had both residual anaplastic and papillary, but we'll look at some other data from some other patients shortly, which is a little bit different. So this is the pre-treatment anaplastic thyroid cancer. You see these very ugly cells here. And then this is post-treatment. You see a lot of fibrosis here. And you can see a lot of this is just fibrosis. And that's because these drugs, they induce a significant inflammatory response along with the dramatic reduction in the tumor that then turns into fibrosis over time. And so you see all this fibrosis here after treatment with DTP. These are fibrotic areas of treated tumor, and you see these scattered viable tumor nests here, and this is a little bit higher power here, looking at the viable tumor nests. So this makes for a challenging surgery. You can imagine, we've all dealt with necks which have been radiated and doing surgery in a radiated neck. Well, this is maybe not quite as bad as dealing with the most significantly fibrosed radiated necks, but there is quite a bit of fibrosis in the neck, which can make surgery challenging, particularly when you're dealing with a thyroid surgery and a recurrent laryngeal nerve. So when we looked at our first 14 patients treated with this approach, that is neoadjuvant BRAF/MEK inhibition followed by immunotherapy, BRAF/MEK inhibition plus or minus immunotherapy followed by surgery, we do see that for these first 14 patients, almost 60% of them had no residual anaplastic thyroid cancer in the specimen after treatment with BRAF/MEK and immunotherapy. So all of these patients, even the ones that had no residual anaplastic thyroid cancer in the specimen, did have residual papillary thyroid cancer in the specimen. And again, this goes back to understanding the lineage of these BRAF mutated, B600E mutated anaplastic thyroid cancers. They are all derived from a papillary thyroid cancer lineage. So even if the anaplastic thyroid cancer completely resolves with the BRAF/MEK inhibitor, with or without immunotherapy, the papillary component remains. And then for those patients who did not have a complete pathologic response, so these 6 patients had some residual degree of anaplastic thyroid cancer in the specimen at varying degrees, varying percentages. They also all had residual papillary thyroid cancer in the specimen. So when we look at these patients in terms of these first 14 patients, the first thing to notice is that many of them present with stage 4C disease, that is metastatic disease. That does not preclude them from being able to potentially undergo surgery. And we'll see some more data on that in a minute. But all of these patients present with either unresectable disease due to carotid or mediastinal vessel involvement or significant prevertebral muscle involvement, or they have laryngotracheoesophageal invasion. And so that's something we typically would try to avoid upfront in a patient with a massive disease burden of anaplastic thyroid cancer, particularly as many of these patients have distant disease. But you see after neoadjuvant therapy, they're able to undergo more standard thyroid surgery, thyroid central lateral neck surgery, which would be typical of what we would be more commonly doing as opposed to these more radical surgeries, which we would try to avoid. And so it just goes to show that we significantly decreased the degree of surgery and the surgical morbidity in these patients. And so if you look at a few sort of pictorial examples of this, you can see again, level of the hyoid bone here, carotid artery encased. After BRAF/MEK inhibition, this tumor is now resectable. The same level, you see the carotid artery and you see no tumor there. Again, this is after 5 months of dabrafenib, trametinib, and pembrolizumab. So the so-called DTP combination, tumor encased here, carotid artery encased, my tumor that is, and you see at the same level now, carotid artery looks okay, and the tumor really is now, for the most part, confined to the thyroid gland. Now, that's not to say that there's not going to be a lot of fibrosis in the surgical field, but a dramatic reduction in this tumor over the course of 5 months of treatment. Another example where you have a patient, here's a PET scan and the corresponding CT scan where you see that the tumor is actually invading into the trachea right below the cricoid. And so this is somebody who would require a laryngotracheal resection. After BRAF/MEK inhibitor therapy, now you see this patient has tumor that has significantly regressed and is now essentially confined to the thyroid here. So dramatic responses which significantly alter the surgical extended resection and morbidity. So this patient, again, going back to the same patient who initially presented in 2017, he got postoperative radiation with continued pembrolizumab. If you remember, he did not present with this particular patient, did not present with distant metastases. And now he is almost 4 years out with no evidence of disease on CT or PET imaging, which is quite a small miracle in a disease that typically would have been rapidly fatal on the matter of a couple of weeks. And this is all with a good quality of life. So he does not have a trach, he does not have a PEG. So, and this again was a BRAF mutated, BRAF V600E mutated anaplastic thyroid cancer patient. So we published our experience with our first 6 patients with this approach: neoadjuvant BRAF MEK inhibitor therapy followed by surgery. This was published in Thyroid last year, and these were our first 6 patients. And this is the pre-treatment and the post-treatment scan for each of those patients prior to surgery. So you see fairly significant responses from the drug that then allow the patient to undergo surgery. We recently published our first 20 patients with this approach. Again, neoadjuvant therapy, BRAF MEK inhibition, with or without immunotherapy, followed by surgery. And these patients were treated, some of them were treated on clinical trial. About 55% of them received postoperative chemo-XRT. The other 45% did not receive radiation therapy. And you see we have very good outcomes. So only 4 of those 20 patients have died. The median follow-up is almost 1.5 years at this point. The longest is it's now 46 months. Median overall survival is not reached. And this is in a cohort of patients who, many of them, 60% of them, presented with distant disease, making that survival all the more remarkable. We've had good local regional control in this patient, and their functional status is good. We've had 3 patients with a temporary PEG, patients who underwent radiation therapy, and none with a long-term PEG, and 3 patients who had a permanent tracheostomy tube, all of whom were patients who had presented with vocal cord paralysis and also underwent radiation therapy. But overall, very good functional results. And so this, we published this in August of 2020 in JAMA Oncology. So these were, again, our first 20 patients treated with this approach. And this is sort of just as a sort of a reference. It is not a direct comparison. These are patients who had the BRAF mutation, underwent the BRAF MEK inhibitor therapy, and did not have surgery. Again, these are comparing apples to oranges because this is a very select group of patients who underwent surgery. But in this select group, clearly our median survival is not reached. We see, at 1 year, we see a survival of over 90%. And our median follow-up at the time of the publication of this was, for this cohort, was only 1.2 years, but now it's closer to 1.5 years. So very good survival results in this cohort. When we look at our overall anaplastic thyroid cancer experience, and this is again from that same journal publication in JAMA Oncology earlier this year, we see significant improvement by time period. So that initially we looked at the 2000 to 2013 time period, and then the 2014 to 2016, and the 2017 to 2019, the last 3 years. And you see stepwise significant improvement in survival over this time period. So it's such that in this 2017 to 2019 time period, we're now seeing 6-month survival rates at 80%. This is all comers, and 2-year survival rates of 43%. So this is very remarkable for an anaplastic thyroid cancer population. So why are we seeing this? So we're increasingly using targeted therapy for patients who have targetable mutations. The premier example of that is the BRAF mutation and the BRAF MEK inhibitor combination. So you see almost 60% of over 60% of our patients in the last 30 years, those who presented between 2017 and 2019, have gotten targeted therapy. And you see these patients who undergo targeted therapy expectedly do a lot better in terms of their survival. Immunotherapy. So you see in the most recent time period, 2017 to 2019, you see almost half of these patients underwent immunotherapy. Again, another reason why we think we're seeing improved survival. And then you see surgery post-neoadjuvant therapy, whereas we were not doing that previously. Now, 15% of our patients have undergone surgery followed by neoadjuvant therapy in the last 3 years. And so all of these are reasons why we think we're seeing improved survival. The clinical trials currently at MD Anderson, which are open or are opening in the next month or two, we have neoadjuvant atezo vimorafenib cobimetinib trial. This was a trial which I'll speak about briefly in a few moments. The principal investigator is Maria Cavanillas, and more than 50 patients now have been enrolled, and this was presented at ASCO in 2020. We'll look at some of the data here shortly, and we still have a few slots left open on that trial, but other upcoming clinical trials. So I'm the principal investigator for a neoadjuvant dabrafenib, trametinib, and pembrolizumab trial, followed by surgery for BRAF mutated anaplastic thyroid cancers, which will be starting in January, February of 2021. And then Maria Cabanillas will be leading a pembrolizumab lenvatinib trial for BRAF wild type patients. Also should open January, February 2021. So if we look at the most recent trial, the Tasalizumab trial, so Tasalizumab being an anti-PD-L1 immunotherapy drug. So we're going to focus on these two cohorts, the cohorts of patients who had a BRAF mutation and those who had a RAS or an NF1 mutation. And so the patients who got a BRAF mutation were on a BRAF MEK inhibitor combination plus immunotherapy. Those who had a RAS mutation were on a MEK inhibitor, cobimetinib, plus immunotherapy. And when we look at these two cohorts, so these enrolled, these two cohorts enrolled roughly 20 and 16 patients respectively, and these numbers are actually a little bit higher now because these numbers have increased. Nearly 70 in cohort 1, which is the BRAF mutated cohort, nearly 70% of patients were alive at 2 years, which is, again, for an anaplastic thyroid population, is quite remarkable. Even in the patients who were not BRAF mutated but had a RAS mutation, which has historically been very challenging to treat, the median overall survival was 1.5 years, which is, again, quite remarkable in that cohort of patients. So this is the trial schema for this is now set to begin in early 2021, dabrafenib, trametinib, and pembrolizumab for BRAF mutated anaplastic thyroid cancer. And just to summarize here, why neoadjuvant therapy followed by surgery for patients with local, regionally advanced, and distant metastatic anaplastic cancer. We know distant metastasis almost always drives survival in anaplastic cancer. We know that the BRAF MEK inhibitor combination with or without immunotherapy will help some unresectable tumors become resectable. And we know that there are now available effective targeted therapies, particularly for these BRAF mutated patients. There are also some other examples which we haven't had time to discuss, including RET inhibitors for anaplastic thyroid cancer patients who present with RET fusions, and NTRK inhibitors for anaplastic thyroid cancer patients who present with NTRK fusions. Now, those only represent about 1% to 2% total of anaplastic thyroid cancer patients. But the BRAF mutated patients are representing about 40% of the patients, represent a significant opportunity to alter the course of the disease in those patients. And also we've demonstrated that it will decrease the morbidity of the surgery. We showed examples of how we not only made unresectable tumors resectable, but actually made surgeries that would be a laryngotracheal resection or esophageal resection into more manageable thyroid central and lateral compartment surgeries. So while we're not going to cure all of these anaplastic thyroid cancer patients, this is a slide I borrowed from Mike Tuttle several years ago, and he sort of shows how anaplastic thyroid cancer patients rapidly progress to death, while those who are radioactive iodine responsive do the best here and make it to actually the goal line, which is long-term survival. But we're actually changing the landscape of this. We are going to achieve long-term survival in some anaplastic thyroid cancer patients, and even those that ultimately will not ultimately survive their disease in the long run, they're having significant improvements in their survival and also in their quality of life. So the next disease I wanted to discuss briefly in terms of neoadjuvant therapy is differentiated thyroid cancer, particularly papillary thyroid cancer, and looking at vemurafenib, which is it's a BRAF inhibitor. This study was led by Maria Cabanillas and myself and several other medical endocrinologists and surgeons participated in this trial at MD Anderson. This data was originally presented at the European Thyroid Association in 2017, and we hope will be published in the coming months. So we enrolled 17 patients in this trial. Again, these are papillary thyroid cancer patients. 14 of them were able to complete 56 days of vemurafenib, and you see the waterfall plots here. So only 3 of these patients had a partial response. The rest had some degree of response between 5 and 30% regression. But you see this partial response was only these 3 patients here. And you look at 11 of these patients ultimately had surgery, whereas 8 of those were able to achieve R0, R1 resection. 3 of them had an R2 resection, and 3 of them were not able to undergo surgery. We did have a couple of complications, relatively minor donor site hematoma, but one patient actually, a major complication was a fatal hemorrhage 2 weeks after the surgery. And this was a patient who had a previous surgery elsewhere, attempted surgery, and carotid involvement. And we treated him with this drug. Unfortunately, this was a combined case with thoracic surgery, vascular surgery, head and neck surgery, and plastic surgery, but the patient did have an unfortunate outcome in this case. So just to show you that these are very advanced patients and often very sort of heroic surgeries to try to cure their disease. But what we learned from this trial is that, and you can see this from the, we showed these responses earlier to the drug. Even in this sort of cohort of advanced papillary thyroid cancer patients, we're not seeing the dramatic responses that we're seeing with anaplastic thyroid cancer. Again, you see 3 patients who had partial response, and the rest would be considered stable disease, anywhere from 5 to 30% response. So, what we learned is that the overall responses are generally modest, and stability is more of the norm. You will see some patients who have what we would call a partial RECIST response greater than 30%, but most of them have between a 5 and 30% response. And the responses are generally inversely proportional to the pretreatment growth rate. If you have a very biologically aggressive tumor that is growing quickly, that tumor will often respond nicely, more rapidly and more dramatically to a BRAF inhibitor than a tumor which has been slowly growing over years. We didn't see that the extent of surgery typically changes a lot, and that's typically because, again, if stability is the norm, then typically you're not going to see dramatic changes in the surgery, in the ability to do the surgery or the extent of the surgery with that approach. But it can be a very good strategy for patients who have residual disease after an incomplete surgery and for whom you're trying to buy time before putting them through a second surgery, especially if there's inflammation and scarring from a previous surgery. Maybe they had an attempt at surgery which was unsuccessful, and they need some time, and they have a more biologically advanced papillary cancer with local regional advanced disease. This can be a good strategy for those patients. So the last cancer we want to discuss is medullary thyroid cancer, and how are we looking at combining systemic therapy with surgery for medullary thyroid cancer. So to start with, there was really a landmark change in the systemic treatment for medullary thyroid cancer in 2011, 2012, with the FDA approval of these multi-kinase inhibitors, vandetanib and cabozantinib for medullary thyroid cancer. And these drugs were shown to have good efficacy. So you can see the progression-free survival of cabozantinib here. This study was published in 2013. You can see the progression-free survival, cabozantinib versus placebo, and you see a significant difference in the survival here. You do see that these drugs, this is cabozantinib being multi-kinase inhibitors, they can be associated with some off-target effects, and particularly effects, as is the case with cabozantinib, related to VEGF inhibition, and those can be include hemorrhage, bleeding events, fistula, wound complications. And so it is important to keep that in mind when you're combining drugs with surgery. These types of issues can be particularly problematic. And so we hadn't been, in the past, we hadn't been particularly excited about using these multi-kinase inhibitors in a perioperative setting, before surgery in a neoadjuvant setting. So it is also, interesting to note that in these studies, although these drugs are relatively well tolerated, about 80% of these patients in the cabozantinib trial had dose reduction, and about 15% of patients actually had to discontinue the drug due to adverse events. So we mentioned that these multi-kinase inhibitors often have a lot of VEGF, anti-VEGF, and VEGF receptor activity. And that can be seen here. So these high numbers here represent a very high degree of activity for these two FDA-approved drugs for medullary thyroid cancer, vandetanib and cabozantinib, and much more so than even other multi-kinase inhibitors. You see this number 1,600 in 40 here, much higher than the VEGF receptor activity in some of the other multi-kinase inhibitors. And so this led to a black box warning on, this is cabozantinib, for instance, that suggests that these drugs can be associated with perforation, fistula, and hemorrhage. And so, again, a little bit of caution in using these drugs before surgery, although it can be done. There's a little bit higher risk of operative issues. So, looking at these pictures of these multi-kinase inhibitors, you see a wide variety of the types of selectivity of these multi-kinase inhibitors. You see that they have VEGF receptor activity and other kinase activities. That's why you see a lot of different colors here. And we'll compare that in a moment to RET-specific inhibitors. So there's been a lot of talk in 2020 about RET-specific inhibitors for medullary thyroid cancer. So we're going to dive into this issue in the last couple of minutes. So, but first, just as a general overview, when you think about RET-mutated medullary thyroid cancer, it's generally about 60%. You can estimate about 60% of medullary thyroid cancer patients will have a RET mutation. So how do we get that 60% number? Well, we know that about 80% of medullary thyroid cancer patients are sporadic and about 20% are hereditary. So if you look at those sporadic patients, about 50% of those are RET mutated. You see the 50% here. And if you add the 100% of hereditary medullary thyroid cancer patients, which have a germline RET mutation, you end up with about a 60% rate of total medullary thyroid cancer patients who have a RET mutation. And then the second most common mutation being RAS, and then other patients, about a third, 30% of patients, a little bit less, do not have a known driver mutation. So honing in on this RET, against this 60% of patients, it does not apply to all patients with medullary, but these 60%, there's two new highly potent and specific RET inhibitors now completed their first in human trials, and those being selpercatinib and pralsetinib. They're both designed to potently inhibit RET, and this is being the schematic for selpercatinib here. And they are active against RET fusions, and these RET fusions can be seen in papillary thyroid cancer and anaplastic thyroid cancer, as we previously mentioned, as well as non-small cell lung cancer, and also 60% of medullary thyroid cancer patients, the oncogenic RET mutations you see in the medullary thyroid cancer patients. And it's important to note that these RET-specific inhibitors are highly targeted and focused on RET-specific inhibition, such as their off-target effects, those KDR and VEGF receptor effects may be more limited. And we'll look at the data for the adverse event and side effect profile. So this was first looking at the efficacy. This was the Catnip trial, which was recently published in the New England Journal of Medicine. This was just published in August of 2020. This was an open label phase 1 to 2 trial of 65 centers in 12 countries. The objective response rate per RECIST was about 70%. There were 2 different cohorts, those that had been previously treated with cabozantinib or vandetanib. Again, those were the 2 previously FDA-approved drugs. Those patients still had a 70% response when going on this new drug, selpercatinib, this RET-specific inhibitor. And in the patients with no previous treatment, their overall response rate was about 73%. The side effect profile, the most common grade 3-4 treatment-related adverse events were hypertension, transaminitis, and diarrhea. But these drugs were generally very well tolerated. So only 30% of patients had dose reduction due to treatment-related adverse events, and only 2% of patients had to discontinue due to treatment-related adverse events. And if you remember several slides back, I showed that data for cabozantinib, which is a multi-kinase inhibitor, that clinical trial in 2017, these numbers were 80% dose reduction and 16% discontinuation. So much lower side effect profile, much less dose reduction and discontinuation in this RET-specific inhibitor trial as opposed to previous trial with the multi-kinase inhibitor. Pralsetinib, which is formerly known as Blue 667, another clinical trial, and this data was presented by Mimi Hu at the European Society of Medical Oncology in 2020. Overall response rate of 60% of those patients who had been previously treated with cabozantinib and vandetanib. And then when you look at those patients who had not been previously treated, overall response rate of 74%. So significant responses in this patient population. Pralsetinib, similar to selpercatinib, a good safety profile, well tolerated. The adverse events, typically transaminitis, hypertension, neutropenia, were the highest percentage of grade 3 events. Only 4% of patients had to discontinue treatment due to treatment-related adverse events. So typically very well tolerated drugs. And these 2 clinical trials ultimately led to FDA approval of these drugs, selpercatinib in May of 2020 and pralsetinib just last week in December of 2020 for RET-altered thyroid cancers. And again, this is not only medullary cancer, this also includes papillary and anaplastic thyroid cancers that have RET fusions. Medullary thyroid cancers, of course, being those that have RET mutations. Just to briefly note that there have been a few patients in these trials who have shown some resistance to these drugs after being on these drugs for some time. This would be expected with targeted therapy. Oftentimes, we do ultimately see resistance in some patients, and that has been seen, although there is a new drug, TPX-0046, which is a novel, highly potent RET SRC inhibitor, which is being studied to overcome this potential resistance to selpercatinib and pralsetinib. So, the idea of neoadjuvant therapy for medullary thyroid cancer. So first, just to say, there's not a lot of data yet on this, and so this is sort of a novel concept, which is it's good for you to be aware of, but please understand that this is a concept that should continue to be studied in clinical trials. So the idea behind it is that these new RET-specific inhibitors have very little activity against VEGF receptor, as was mentioned. They have a lower side effect profile, and possibly we can surmise that they may have improved safety with surgery. So we can consider surgery in combination with these drugs. We also know that distant metastases almost always drive survival. That this neoadjuvant approach allows upfront treatment of the distant disease while also giving the opportunity to shrink the local regional disease to cause regression, significant regression. We saw those overall response rates in the range of 60 to 75%. So if we can achieve that for the local regional disease, we can imagine that that could result in a significant decrease in the morbidity of the surgery of the patients who have significant response. And again, this is not for all comers. This is only for patients who may have local regionally advanced medullary thyroid cancer with or without distant disease. And so just to present a case example to sort of illustrate this concept, and this paper has now been published in Head and Neck, Neoadjuvant Therapy for Advanced Medullary Thyroid Cancer. You can look it up now in Head and Neck. It was published several months ago. So a 20-year-old, otherwise healthy gentleman presents with sporadic medullary thyroid cancer. And by the way, this is open access, so anybody can access it in Head and Neck. So his calcitonin is over 10,000, his CEA is almost 1,000, and he has bone metastasis as well as lung, liver, and renal metastasis. Again, he has a sporadic medullary thyroid cancer, meaning he is germline RET negative. But, so actually before I get to the but, let's look at his imaging. So you see he has a relatively small tumor in the thyroid, but he has a lot of lymphadenopathy. So this is in the low left paratracheal area. This is actually this red arrow indicates the subclavian artery, and you see this tumor is 180 degrees around the subclavian artery. If you look down here in the mediastinum, obviously here's the sternum here. You see the trachea here and the aortic arch here, and you see this large tumor mass right at the on the left side near the aortic arch, which is right where we all know that on the left side the recurrent laryngeal nerve passes under the aortic arch. You can see it on the other side here, still tumor. So that's a significant, this bulky lymphadenopathy in the tracheoesophageal groove and in the mediastinum is a significant risk, not only for dissection around the subclavian artery in this case, but also the recurrent laryngeal nerve. So we tested his tumor he has a sporadic medullary cancer. And remember, we said that 50% of these patients with sporadic medullary thyroid cancer will have a somatic RET mutation. So we did a core needle biopsy, or you can do an FNA cell block of his tumor, and got a RET mutation. And so we considered what the initial management for this patient. And so there's several options. So, and not a right or wrong answer, but I present this to you just to say that this is not black and white. And just because what we decided to do does not mean it is the right answer. We did this in the setting of a single patient clinical trial, which we'll talk about shortly. But so one option is surgery. So you can remove the local regional disease, and then understanding that you would need to treat him for the distant disease as well with some type of systemic therapy. You can treat him with the systemic therapy up front with the multi-kinase inhibitor older drugs that were approved for medullary thyroid cancer about 10 years ago, cabozantinib and vandetanib. Or you can consider the newer RET selective drugs, which have just this year been FDA approved for RET mutated medullary thyroid cancer, selpercatinib and pralsetinib. So in this case, we did treat the patient on a single patient protocol after approval from the FDA and Loxo Oncology with selpercatinib. So you can see in 2018, he was started on selpercatinib, and this is actually what his calcitonin level was at the time of treatment. It should also be mentioned that he did get 2 weeks of radiation to his spine. As I mentioned before, he had those 2.5 centimeter spine lesions. So we treated that with radiation just to stabilize the spine. Otherwise, he got no treatment other than the RET-specific inhibitor, selpercatinib. You see his calcitonin was 16,000. And 2 months after starting selpercatinib, so this was August to October, his calcitonin dropped from 16,000 to close to 2,000. So significant reduction in his calcitonin in a very short period of time. And this is typically what we will see with the decline in the tumor markers with RET-specific inhibitors. You see these are waterfall plots of these patients, and almost all of these patients have an 80% reduction in their calcitonin, and some are 90, 95, 95+% reductions in the calcitonin. You see a substantial decline in CEA as well, although not as dramatic. And so You also see the structural response. So this patient, I believe we measured a resist response, which was about 51% in his neck. So 50+% reduction in his tumor burden here. You can see this makes this interface with the subclavian artery much more palatable in terms of surgery. And you also see this disease in the mediastinum here, significant reduction in the disease, which is approximating the aortic arch there. And so at this point, we have an option. And again, not a black or white answer here, neither right or wrong, but should we continue this selpercatinib indefinitely? He's been on it for 5 months. He's had a dramatic response, both structurally and with his calcitonin. Or do we use this as a window of opportunity to do surgery for this patient with the understanding that he will need to go back on the drug? So there's pluses and minuses of this. So one person could argue that leave this patient on the selpercatinib indefinitely until he progresses on that, and then switch treatment. But you could also argue that at the time of progression, and again, we are seeing a few patients develop resistance to these drugs, is not the best time to be considering alternative therapy, especially surgery for these patients, especially since they may need to go on, a multi-kinase inhibitor or other drug that may not be as palatable with surgery. And so, one approach is to use this window of opportunity where you've had a significant rapid reduction in the tumor burden in the neck to consolidate that local regional control, which is indeed what we did in this particular case. So we did a thyroid central and lateral neck surgery as well as superior mediastinal surgery, removing 104 lymph nodes, 36 of those having tumor. The patient doing very well, and then looking at his overall response over time. So we already saw that his selpercatinib dramatically responded after a couple months, and then when we held the selpercatinib for surgery, we saw a significant bump back up in his calcitonin. So, which we only held the drug for about 10 days, but that was enough to bump his calcitonin. But then following the surgery, we see his calcitonin went back to its lowest point ever, to below 2,000. And then over the subsequent course of months and even year up to October 2020, we see that the calcitonin is now about 60. So you went from a 16,000 level of calcitonin to 60 over the course of a couple of years using the RET-specific inhibitor and also integrating surgery into that approach. So I think this is our last slide, just to say that we will be studying this concept in clinical trials. This is a neoadjuvant RET-specific inhibitor clinical trial with selpercatinib. In this case, for RET-altered thyroid cancer, most of these patients will be medullary thyroid cancer patients with RET mutations, although we will also allow papillary cancers or anaplastic cancers with RET fusions to enroll. And we're treating them with neoadjuvant therapy followed by surgery. And then they have the option of going back on the systemic therapy following surgery. And we will be doing this, leading this from MD Anderson, and as well as Harvard, Mass Eye and Ear, Johns Hopkins, Memorial Sloan Kettering, and probably several other cancer centers in the United States. We're hoping to enroll 30 patients in order to further study this idea of neoadjuvant RET-specific inhibitor therapy for RET-mutated thyroid cancers. And we hope to share those results with you in the coming years. So the conclusions: the evolving role of targeted therapy in surgery in aggressive thyroid cancer. So we've looked at anaplastic thyroid cancer. Our retrospective experience in recent clinical trials support neoadjuvant therapy followed by surgery as a potential new standard of care for BRAF-mutated anaplastic thyroid cancer. We have an upcoming clinical trial, which I showed, dabrafenib, trametinib, and pembrolizumab, which will provide further data to support this, we believe. For advanced differentiated thyroid cancer, the responses to BRAF inhibitors are generally modest and proportionate to the growth rate, but it is a good strategy for patients who may benefit from a delay in surgery or for whom you're trying to avoid surgery due to the morbidity of surgery. And for medullary thyroid cancer, this study of RET-specific inhibitors as neoadjuvant therapy is in its infancy. We mentioned the case report, which is now published in Head and Neck, and the new clinical trial, which will begin in early 2021. So with that, I've included my email address here, mzafereo@mdanderson.org, in case any of you would like to ask questions. It is my honor and pleasure to present to you anaplastic, medullary, and differentiated cancer, the evolving role of targeted therapy and surgery, to the Venezuelan Caracas Head and Neck Surgery 2020 conference. Thank you from Houston to Caracas. Peace, blessings, and safety during this Christmas season. Be well.